All right, all right. Good to see you as always. I mean, I don't know. We haven't done a webinar together in, I don't know, like 4 weeks. I've been starting to miss it. So um, we'll also be joined later on by Dr. Kathy Westbrook as well, just to be able to kind of get her take on this. And why are we here today is we're here to launch in earnest ScanLabMR. Now, you may be wondering what ScanLabMR is, and I'm going to show you because it's a little bit easier just to show you rather than try to explain it too much. And so what I'm going to do is do a demo and things like that. Feel free to ask any kind of questions that you want, either on, right on here on Zoom or on Facebook, which we are broadcasting to the MR Safety Group. And one thing we want to really highlight in the first half of the presentation, which is why Toby's here with us, is that what the safety aspects of ScanLab is. And so from that perspective, the purpose of ScanLab is to simulate. I mean, the closest thing you could say this thing is a simulator. But the idea of ScanLab is to simulate all thought processes that occur while we are usually only scanning a patient. So you can imagine sometimes that can be difficult if you're behind schedule. How do you objectively know how good you are at your job? And ScanLab is going to be the first education tool or quality assurance tool that can objectively grade a technologist and how well they do their job and help new technologists get better. So with that said, I'm going to get started. All right. Okay. Okay. Okay, so the first thing we're going to start to discuss, let me get this up here. There we go. This is www.scanlabmr.com. Usually you can come here and log in. Up until now, ScanLab is not for individual sale. It will be for sale within cohorts. So for universities that are teaching students and for hospital organizations for now. But you can go ahead and just log in. So if I log in, it should take me to app.scanlab.com. And so we can go down to the home screen, and just within my own login, what I can do originally is I can start out with my preferences. And so in this case, you get to choose GE, Hitachi, Philips, Siemens, or United. And this doesn't change our interface. What this actually does is make windowing and leveling, behave the way that you would on a Siemens or on a GE. As you know, GE and Siemens are left and right-handed systems, and so that maybe on GE you click and go down to the right, whereas in Siemens you go up and to the left. And so it's a lot of our students have really liked this because if they're going to be on a GE one day or Siemens on the next, they can go and kind of prepare and get up here. Also, from this standpoint, we also are translatable immediately to 117 different languages. And so if English is not your mother language, then you can be able to translate the entire site immediately to any one of these languages. Now, it's not going to work very well for me or Toby. Oh, Toby maybe a little bit more fluent in Arabic than me, but I'm going to go back to the old English. So after this is set, we'll come back to our statistics and account information and things like that. But within the account information, nothing crazy here. But as a whole, this is the beginning after you've signed up. So right here, we have either a random test or we have a test by region. In this case, you can see all of the different ScanLab examinations. And we'll get into that a little bit later, but we have 13 different examination or regions. And then within each region, we have examinations. And as time goes on, and I think we have 24, 25 examinations, but as time goes on, we're going to be adding more and more and more. So, and one of the big things that we want to do, so let's just do lower extremity, sure. Do lower extremity, and you see in here, we have ankle, foot, and knee. Now let's go ahead and load the knee. Now, this is one of the aspects of MR safety inside of the scan lab, because we want to also influence the user and condition the user to always think safety before you'd ever enter the scan lab and start to actually prescribe slices and things like that. And so before you're able to start the scan lab examination, you are going to go into the scan lab safety check. Now, in real life, right, we're not going to take the patient in, put them on the table, and then say, well, what implants do you have? We want this to be something that will condition you to think about these kinds of processes. Now, just in case you are not an MR safety officer or anything like that, we want to keep you within scope. So what is that scope? You know, it is not our job within our scope as technologists or radiographers to be able to individually be clearing implants, but we want you to be able to look at these scan lab screening forms to be able to understand, is this patient a candidate to go into zone 4? This is something that usually would be taking place in zone 2 or zone 3. So that's what we're going to do right now. So you see we have the different options. So review the MR screening form, assuming the patient is changed, removes all loose items and body piercings. Is there anything on this form that could be a potential safety concern that requires additional clarification? And so either no, proceed with examination. Yes, incomplete history. So we'll have to get more information from the patient. Let's say the patient just goes in zigzags or says, yeah, I've been here before. Well, they could have been here before for a CT, you know, so contrast is not necessarily contrast, things like that. An unclear implant, additional device information or screening could be needed. So that's for us just to be able to say, okay, there is something here that I need to discuss with my reading radiologist or my supervising radiologist. So, you know, whether that's a neurostimulator or some sort of defibrillation device, we need to be able to run that by someone else. Additional foreign body screening needed. That could be a patient has a history of being shot or has, you know, maybe was a welder or something along those lines and has, you know, some kind of chance of having metal in the eye. Contrast or renal concerns, or if there's more than one renal concern or more than one contraindication or concern, we would hit multiple concerns or contraindications. So let's take a look at this patient. So we're doing a left knee with and without contrast. And so down here, the diabetes and kidney dialysis kind of thing becomes a lot more important. So this patient is female. They ever had MRI contrast before? No. You ever had metal in your eyes? Okay. Patient has metal in their eyes or could, you know, there is a possibility for metal in the eyes. If I go through here, there is nothing. Obviously, we're going to, in real life, going to need to confirm that all these things are true with our patients. Also, body piercing, but that's been removed. Bunionectomy, okay. Very brave surgery. Okay, come through. Okay, so I've gone through and I think, for me, that in this case, we would need to have an additional foreign body screening needed. So maybe, depending on what your standard operating procedures are, maybe that's a 2-view orbit or, you know, something along those lines. So that's the first aspect of safety for the scan lab. Toby, what do you think? Any questions?
So far, no. I think it's fantastic that even before you get into the simulator, you're walking people through the normal technologist radiographer steps in terms of clarifying, you know, concerns with the patient. I think it's great.
Good, excellent. And then we'll go into some other safety things that could, you know, that could pop up here in the next couple of minutes. Okay, so I'm going to go ahead and submit my answer. And then from this case, now you are within the ScanLab. So assuming that we have just cleared this patient, or we did a foreign body screening and everything was okay, we have the go-ahead from our supervising radiologist to continue. So now we are in ScanLab. So just let's go over some aspects of the actual ScanLab user interface. So you will have 3 questions in this case. Sometimes it's 4, sometimes it's 5. It could be anything. When we release cardiac later on this month, you could have 40 questions. So have fun with that. And you can also answer them in any order. So if you decided, in this case, we have an axial, sagittal, or transversal slice, or coronal slice, we can be able to answer those in any order. But we have, based off of some of our criteria, we do have these in a certain order for a reason. But it doesn't mean you have to do that. We'll get to answer criteria in the drop down here in just a moment. Let's say, for instance, so prescribe a sagittal slice of the knee. So, and we give you that guidance because you are going to be graded on how well you prescribe slices. So we have a panel of experts that we get together, that I'll introduce one of those in a few minutes, that we create the angles and the slice thickness and the gaps and all the parameters and what we will allow, which is, field of view might be way too big, field of view might be way too small. You need to be able to cover the anatomy that you want. And so in this case, we are saying the angle is parallel to the ACL because we've chosen the ACL criteria, perpendicular to the femoral condyles, and for slice coverage to include the medial femoral condyle and the proximal tibiofibular joint. So maybe some people will say, well, Matthew, where I work, we do not angle with the ACL, we angle with the condyles. Okay, you'll only be judged based off of what answer criteria that you have selected. And so if you do want to do parallel to the condyles, you'll see I just changed parallel to the condyles, and now my answer criteria has also changed. And so we don't just put you out on an island. We say, hey, listen, this is the correct answer that you will be judged by. Well, let's say I like the ACL. And so let's go over here. So within this is also, the ScanLab is compatible completely with a tablet or your phone, although for now we really want to focus on PC. But in this case, if I was to click on move, I'm moving. So this is all depending on what happens when you left click. So if I'm hitting resize and I left click, I'm resizing. If I rotate and I left click, if I pan, so you get the idea. So for me, I keep it on move usually, unless if I'm on an iPad or something like that, I can completely do this. So within the ScanLab, you'll always, right click will always be zoom, and middle click will always be window and level. If you get completely lost here, you can always double middle click, and it goes back to the original window and level. Or you can also do it down here, this automatic window and leveling. You'll see here, if we zoom this up, we can be able to see these dots are responsible for adding more slices, or depending on what you've got down here. So this is something to think about. If I have the number of slices unlocked, when I do this, the number of slices are what change. If I have slice thickness unlocked, then the slice thickness is what changes. So let me just get rid of my OCD here is about to lose its mind. So let's get this back to a nice round number for a moment. So there we go. So you'll see in the corners, we have our rotate. Any corner really doesn't matter. And then we can be able to, in plane, to open up our field of view. Okay. Also in the center, just in any one of these things, we have just a regular, kind of move the entire stack. We also have the phase encoding direction that you also are judged on. So in this case, our phase encoding direction, maybe I'll keep it this way just for fun, but normally in a knee, you want to keep the popliteal artery from being able to wrap and or ghost directly into your anatomy of interest. So anyway, if you ever get, sometimes things get crazy inside of MRI, you've got like 80 obliques or something along those lines and things start to get a little dodgy. What you could do is come over here and say, let's just reset this to a straight sagittal, just to where you can kind of reset. And what that's going to do is orthogonally change these to a true axial, a true sagittal, and a true coronal with really no obliquity at all. If I say, well, ScanLab, I don't like these localizers that you gave me. You've not given me the amount of information that I need. I can always go into localizer mode. So in this case, if I go into localizer mode, I have really inside of localizer mode up until now, we have just the slice gap. So if you wanted more, we don't give you the option for more slices. We give you the option for the gap in between them. And you will get one localizer before you start to lose points, because the idea is that I wish we could scan localizers all day long, but we got to get cracking at this. And so you can be able to, change your localizer and be able to rotate everything together. But I like our localizer. I think it's good enough. So I will cancel add localizer, and we're back into the normal mode. Okay, we can also choose to temporarily turn off or on our slices as well. Okay, so let's actually, oh, one last thing. If we're ever on our phones or on our tablet and we want to look at some bit of anatomy that's a little bit more involved, we can always double click and take us up into individual, highlighted mode, and just double click to get back to the overall user interface. So let's get started. Let's go on question number 1. And I am not looking to ace this test, and I'll show you why a little bit later. But let's go ahead and get started. One of the things I need to make sure within the ScanLab, let's look at the criteria: perpendicular to the femur, parallel to the femoral condyles, and include superior to the patella to the tibial tuberosity. Okay, I can do that. But I need to make sure that my slice thicknesses are okay. From this perspective, they're not. We have to have a number that we put in there. And I think one of the big things inside of MRI is that a lot of times the tech is never asked what would be the appropriate slice thickness and gap and field of view and things like that. The idea is that we don't want to have, as Kathy calls it, a lot of fresh air outside. We want to be able to take advantage of our field of view. We want to be able to take advantage of our slice thickness. Obviously, the smaller the structure that we're looking at, the thinner the slice thickness we're going to need to have, or less gap or things like that. So, and we'll get into how we came up with these ranges. But in this case, let's say we want to prescribe, let's say I will go a 4. Sure, I'll do a 4 skip 1 in this case. So in this case, we have 4 millimeter slices and 1 millimeter gap. So I can go up, and I'm just going to pay attention, really close attention to my criteria. So coverage, okay, yeah, I got it. And we will mess this up a little bit, to be honest. So usually you would take this little line, and I've always wished on any kind of manufacturer that I had a perpendicular line. And so this is your perpendicular line that obviously goes parallel or perpendicular to your slices. So I'm just going to angle this with the femur. And we want this to be off a little bit, just because we get feedback at the end of every ScanLab exam. So I don't want this to be perfect. So let's mess this up a little bit. Okay, sounds good. You'll see we also want to be right to left. So that popliteal artery is phasing right to left. Now, I want to get all the way to the insertion right here at the tibial tuberosity and a little bit higher, but let's mess that up as well. We don't quite get there. Oh, and since I'm on slice thickness, there we go. Take this back to 3. There we go. So now we can be able to add or remove. Okay. So another thing that we wanted really to be different within ScanLab is that in other simulators, you never see what your image would actually look like. No matter what, if I did an axial, you'd always get a really good axial. Even if my axial looked like this, I would get a really, really terrific axial. Usually, they have predetermined outputs. And so we really wanted there to be a cause and effect within this. And so I'm going to see exactly what my pictures would look like within this. So I'll go ahead and hit scan. Okay, I can name this. Let's just say my axial. I'll hit OK. So now within our axial area, we are seeing exactly our field of view and all of our angles. Now, if I turn this off for a moment, I could be able to go in and kind of admire my handiwork a little bit and be able to see what it is that we really can expect, right? Because everybody, we all, as techs, as seasoned techs, we understand that if you put a bad axial out there, it's making your sagittal and your coronal harder as well. And so we want there to be a cause and effect inside of ScanLab. And so, okay, so the next thing, it's automatically taken us to question 2 of 3, and we discussed this. I want to stick with my ACL, but it doesn't mean that you can't change it. And and as time goes on, we will add more variant angles within the ScanLab. Now, once again, I'm going to say, well, if I'm looking for my ACL, maybe I go 2.5 and skip 1. Okay. And so what I'm going to do is find my ACL, which you can see right here. Sometimes people will do this to where they angle this with the lateral condyle. There we go. And what's my criteria here? Well, my criteria says include from the medial femoral condyle to the proximal tibiofibular joint. So now that we can see we have a good axial, you'll see that we can see there we go. We need to make sure that we get our joint. So I'll open this up a little bit maybe. Once again, I don't want this to be perfect, but it's pretty good. I'm going to go through to my coronal. Maybe I'll adjust a little bit. There we go. And then I can go through. Now, just because I've done an axial doesn't mean I can't go back to my coronal or to my localizer. So you really have, in this drop down, you have everything you've ever scanned before. So if you want to go back to the localizer to see something, you can totally do that just like you can inside of normal clinical practice. Okay, to me, that's let me see, we're kind of, maybe move it a little bit farther posterior. Now, if I were to have too few slices, I start to lose ScanLab scores. If I have too many slices, I start to lose ScanLab scores. Because, either you're going to cover the anatomy correctly, or we want to make sure that you're not wasting extra time, or the user's not wasting time by prescribing additional slices. I was in Dubai at Arab Health, and I had some radiologists come by and talk to me and say, Matthew, I have the most generous technologists. They give me this amount of slices, and we don't want that. We want to be able to be training people from the go that there is a appropriate amount of slices to be able to answer the clinical question. So let's go ahead. In this case, I feel pretty good about this. Let's mess up this angle a little bit, and I will say scan. All right, so Sag. There we go. Okay. So in this case, there is my sagittal. You can see my ACL right here coming down. Okay. And lastly, we have our coronal. So let's go ahead and, okay, let's say 3 skip 1, sure. Let's do that. Now, anybody that's in our session, what is wrong with this picture? So in this case, plenty of you, I'm sure, are if you have a transmit-receive head coil or a transmit-receive knee coil, really, you could be able to go head to foot, or you could be able to go right to left. In this case, we do not judge. So both answers are correct. And so, but let's go ahead and just leave it right to left. And now I can be able to, just like in normal MRI, now I have a really nice axial to be able to say, well, let's take maybe my medial line here. So we wanted just one kind of line to be the focus. Is that going to be Yep, perpendicular to my my condyle or parallel to my condyle. There we go. And I can be able to add that criteria in. Let's make this a little too big. Let's say, oh, I'd like to hopefully get a little bit of the other knee. 2 for 1. So when we're finished with this, you'll notice that I'll hit scan and we can get our coronal back. Okay. All right, so now I have my coronal. You'll see it's a little bit too big. So don't worry, we'll pay the price for that a little bit later. And my scan button has turned into proceed. Now this is your time, if you'd like, to be able to go through and really look at your images and admire your handiwork. In the coming months, we will have something to be able to, let's say you did something and you regretted it. You would be able to repeat that and have a chance to minimize the number of points that you are deducted. Now, 1 repeat only. After that, you start to lose more and more points. So in this case, we can now go proceed. Oh, okay, here is now this is the second aspect of safety that we're putting in here. So after a ScanLab examination consists of the safety check, it consists of the slice quant, so where we are judging you based off of your angles and your fields of view and your slice thicknesses and gaps. But then you go in and it's our job to be able to also simulate the same thought processes that occur in order for you to say, well, what's the appropriate spatial resolution? How do I minimize my scan time without affecting resolution? So we have multiple different categories of critical thinking questions. And so in this case, I can say, so you're standing close to the cryogen discharge pipe that's responsible for safely expelling cryogens in the air in the event of a quench. What zone are you currently in? Let me hand it over to Toby. What do you think, Toby? What if you had to guess?
Most definitely zone 1.
Okay, let's go ahead and do that. So we're hitting zone 1. Obviously, that is not the correct answer. Please don't do that in real life. Do not put your quench pipe in your parking lot. All right, so let's go to the next one. In this case, based on the options below, what could you alter to reduce time without affecting spatial resolution? Okay, so any ideas here? Let's see. Oops. There we go. So in this case, let's go ahead and do this stuff. So incorporating parallel imaging techniques, that's true, because we're skipping lines of K-space rather than actually affecting the number of lines of K-space. So we're not affecting our spatial resolution. Decreasing TR, I mean, absolutely, that can reduce time. Reducing averages. Okay, yeah, averages actually do not affect our spatial resolution. Decreasing imaging matrix or decreasing echo train length. Well, both of these actually do increase or decrease spatial resolution. So if I decrease image matrix, obviously my pixel size, my voxels are going to get larger. And if I increase my echo train length, I evoke more T2 blurring. And so, the longer the echo train length, the larger the difference between inside of the free induction decay. So that's not going to help us. Okay, so I've just done that. Perfect. So which parameters can be used to decrease overall acquisition time of the sequence? Okay, yep, I can decrease. So this is something you would be thinking about normally, like if your patient starts to move, we are trying to simulate those thought processes and also figure out how good you are at understanding these concepts. So within ScanLab, ScanLab's job is not necessarily to teach you. ScanLab's job is to judge you, albeit very sweetly, to be able to figure out how good you are at your job. And so people are starting to use ScanLab as an internal quality check. They're starting to use, ScanLab at universities to be able to instruct their students from the ground up. So overall, okay, decreasing the number of phase encoding lines, right? Because we pay a time penalty for every phase encoding line that we fill. Decreasing TR, sure. Okay. Increasing echo train length, that'll actually decrease the overall time. But increasing concatenations or packages and acquisitions, no. And that will actually cause us to reduce SAR, but at the price of increasing time. So I'll go ahead and submit this answer. Aha. Okay. So let's take a look at this image. So based on this single image, what would be the diagnosis on the MRI report? And we want these because these are more difficult questions. And each one of these questions is rated, and we have hundreds of them inside of here. So you don't know what you're going to get. And we have an algorithm in place that localizes the questions that you've never taken before. And so you're always going to have a different experience within the critical thinking questions of ScanLab. And this is a harder question because sometimes it's also not within our scope to diagnose, but we do need to understand when something is incorrect and we need to get a radiologist's opinion. Oh, hey man, this does not look good. Or excuse me, miss, can you come help me with what this is? I can know that this is abnormal, but is there any additional sequencing that you would like? And so we have some interesting things coming out about that. So in this case, to me, it looks like it's a fracture of the tibial plateau. Yeah. So because, this is a T2, we have bright edema all the way down. You see it going all the way up to the articular surface. And so I'm going to say this is a fracture of the tibial plateau. Okay. Drum roll, please. Okay. Uh-oh. That is too bad. I got a terrible ScanLab score. So this is your ScanLab report at the end of each examination. You recall, we changed the knee to be much, much, much too big, the field of view. So, and we're always assuming a in-plane resolution of 0.1 by 0.1. So right now, ScanLab does not judge you based off of resolution. It judges you up until now on slice prescription, and something else we'll discuss in a minute. So now I can go through and say, why did I get an 85? Let's open up this area so you can see a screenshot of everything that we prescribed. And now, oh, I get it now. I was 8 degrees off of the ScanLab angle, and my slice coverage did not cover the minimum ScanLab range. So you'll see I just clipped the top of my patella. And so it doesn't, in yellow, it means that we didn't do all that bad, just not so bad. All of my greens we did great in. So we prescribed the correct phase encoding. The gap that we prescribed was appropriate for the knee. The slice thickness was appropriate. The field of view, all the frequency, everything was good. Okay, so I can make some adjustments. We do not give you the ScanLab angles and the ScanLab ranges because all people would do is do this. Got it. And now I'm going to pass the ScanLab every time. So shame on you for wanting to do that inside your heart. So if we go to the sagittal, how did we do? Got it. So yep, the phase encoding direction was incorrect. Fair enough. My bad. So, and also, what did we do to get our whopping 3%? So within this case, woo. So it's not just did your maximum ScanLab range, was it exceeded? It was exceeded by a lot. And so the more you exceed that range, the more heavily penalized that you're going to be. Okay. So that is the first aspect of MRI. And then we can go into our critical thinking questions. How did we do from the screening form? Okay, let's check it out. Okay. So due to possible presence of metal within the eyes, an additional orbital screening may be needed for hospital standard operating procedures. So the cool thing about this is that even if you're getting these things wrong, we're still giving you why you got them incorrect. So let's see, you're standing in a cryogen discharge pipe. I think Toby called this as zone 1, but really it is considered zone 3. Now, if this is something you disagree with or you'd like to contest, you can report the question, and we will have our safety panel or our panel of angles or the question criteria review. We want to get better. We're a new company, and we will continue to get better. So we could go through and be able to look at all of these different questions that we answered and be able to get feedback on them. And then I return to my test selection. And at that point, I have completed my first over many ScanLab examinations. Now universities here, they're really excited about this, and we got off the phone with our friends at MD Anderson a couple of days ago, and they were talking about their students' ultimate how well they're doing now in clinic, because this was not supposed to be out for a while. This was still being worked on, but due to COVID, we had a lot of people reach out and say, "Hey, do you have anything? I know you're working on something. Do you have something?" And so it's been really exciting to be able to, for the students that are, they're worried about infection, or they are worried about anything, basically, they can be inside the scan lab and working. And when they arrive at clinic, they've prescribed 400 knees, they've prescribed 300 brains. And so they arrive as assets instead of as liabilities. They already are in the process of knowing they have to think about safety first. They can be graded on what they're good at and what they're bad at. And so their professor or the head of radiology can be able to see who is good at what and be able to address those individual criteria. So Toby, tell me, what do you think? Anything we've forgotten? Any initial impressions?
Well, I think it's great that so many of the tools that are available to technologists and radiographers are siloed, right? We're going to focus on this one aspect of the skill set that you need to have, and whatever falls outside that skill set, somebody else will deal with that at another time. And one of the things that I think is so great about this is obviously ScanLab is really focused on the prescription of the exam, but it doesn't do that at the expense of or ignoring the other elements of a technologist, a radiographer's duties. The fact that you integrate safety, into the patient exam review, the fact that you deal with the technical questions, if we need to affect, scan time or SAR or, resolution, that you not only talk about, okay, how do we customize, the slice selection based on the anatomy, based on the indication, but then you also talk about, okay, great, you got it plain vanilla, but what if we need to throw some complications at you? So I think it's incredibly powerful for the degree of integration, that it's not a silo. It doesn't look at one narrow skill set. It's obviously built around grading slice selection, but it integrates all of these other elements, which I think is, and as somebody who eats, lives, and breathes safety, the fact that that's so tightly integrated into this, I love it.
Excellent. I mean, and everybody that's here, I mean, is at least familiar with MRI. But I mean, we don't just get to focus on safety. We don't just get to focus on slices. As MRI techs and as radiographers and as managers, we're bouncing around. We go through 50, 60 different thought processes for every single patient. And so we really want to try, on the first version of ScanLab, to be able to completely simulate all of those thought processes at random and be able to kind of keep you guessing. Because something else we really wanted to create here is a really safe clinical environment, to where you're not sitting there behind schedule by 45 minutes, or you don't have someone tapping you on the shoulder or calling you on the phone. You can really be able to prescribe these slices, to be able to play in order to, and not affect negatively patient care or quality or anything like that. If you've ever wondered why don't we angle it this way, feel free. I mean, so cool. I'm happy that you like it. I really am. And I mean, this is not the first you've heard of this. I mean, you and I have, I know I've asked you plenty of questions as time's gone on. This is not something that just takes one person to build. This is definitely something that has been a big collaborative effort. And just while I'm thinking about it, a special thank you to Kristen Seitz that helped us, really helped us consult with all of the screening forms. So she's wonderful, and we really, really appreciate her being our friend and helping us get better. So, okay, so Toby, I'm going to get on a new friend of mine. I'm going to help her get on. And, and I actually did not know, even though, I've known of her for a really long time, I did not know Kathy Westbrook personally. I reached out to her by email and said, hey, I've got something that I'm building. Would you take a look at it, please? And she said, sure, absolutely. So I'm going to invite Kathy up here. Let me see. Okay, Kathy, you are now the host, so now you can turn on your, there she is.
Hey, yes.
Hello.
Hello.
How are you today?
I'm good, thank you. Yes, it's great to be here.
Thank you for coming.
That's all right. No, I'm very happy to. And hi, Toby. Good to see you again.
And you too.
Good.
So, Kathy, I know, so just to give everybody a little bit of background, so I would have no business deciding what angles and slices, and that would be the biggest mistake I could have ever done with building ScanLab. And so who am I going to reach out to be able to help me prescribe these angles and ranges and things like that? I want these to be relevant. I want them to be tried and true. I want them to be something are backed up by publications. And so when you know MRI and you think of education, first person that pops into your head is Kathy Westbrook. And so you sit there and you send her a very vague LinkedIn message, and you con her into coming into the group and helping. So someone else who will be joining us this evening is Ann Bright. Ann and Kathy have both written two of the most widely accepted MRI books on slice prescription, angulation, coverage, and everything like that. And so what we would do every morning, I would wake up at 4:30 before my day job. Kathy it would be about 10:30 or so in England, and Anne, it would be about 9 p.m. in Australia. And we would get together and admire each other's pets while they walked across and things along those lines. But we'd tackle one body part at a time. And so, not to say that these ScanLab angles will not change and will not morph and will not get a little bit more specific as time goes on, but I think it's really powerful to take multiple authors of these books and to be able to agree on these angles. So these are for me, it was really important to bring in the best and to be able to give validity to these angles.
Yes, no, I mean, I agree. That was definitely, the right thing to do, because, obviously when you're setting up something like this, you want there to be a consensus of agreement on how best, well, what we were doing was the slice prescription and coverage. And as you say, it is quite a subjective thing, and practice is different, isn't it? So joining of minds, I think, was very important part of this. So no, and it was great to be involved. It's quite fun, actually. So.
It is fun. I mean, I don't know about 4:30 in the morning fun, but I mean, pretty fun. So Kathy, I want to show you some more aspects of ScanLab, get your initial impressions of them, those kinds of things. But once again, thanks for joining us.
That's fine.
Oh, Kathy, can you make me the host real quick?
Oh yes. So hang on. Rename. So I actually don't have that as an option.
Go up to my picture, the guy with the weird
right.
hair.
Okay.
In the three little dots, you can make me the host.
Okay. Yeah. Got you. Okay. There you are.
I've been promoted. It's good to be back. All right. So, okay, let's go ahead. I'll share my screen again. And I want to, there we go. Let's go for screen. Okay. So now we're back within the ScanLab, and let's go to a different region. So, and I know that we are, let's see how we're doing on time. Okay, all right, I'm okay. So I wanted to also show something new that we've worked on, which is the contrast lab. And so up until now, we've really focused on angulations and things like that throughout the entire body. But the contrast lab is going to allow us to take this one step further. So if I start doing, and we won't do an entire contrast lab examination just because of time, but we still have the exact same overall interface, but with some new things. So right now, instead of just saying prescribe me an axial or a sagittal, now I'm saying give me a sagittal T1. So within this, we would have to know our slice thicknesses. Let's say I do a 5 skip 1, whoops, 5 skip 1. And I can be able to choose, am I going to do a gradient echo or a spin echo? With a gradient echo, I have the option for flip angle, because obviously, you know, with a gradient echo, flip angle is going to give us the predominant contrast and weighting that we're wanting. And then spin echo, we have the option for fat suppression and inversion recovery. If I choose inversion recovery, it's going to give me the option for my TI. So, but in this case, just real quickly, we will go through and we will be able to show, let's see, yep, there we go. Sagittal, I don't mind it. Want to make sure I'm covering, I'm phased A to P. Okay. As my daughter walks inside of this room. Good morning, honey. All right. The joys of working from home. Okay, so now I need to make sure that I want a T1. So let's just do some weird TR and a TE of, let's say 6 RTE. Okay, so now we have these. I feel okay about everything, and I'm going to hit scan. So not only are you going to be able to see the image that you're getting in terms of angulation, but now from a synthetic standpoint, we can be able to calculate. Okay, let's do sag. And if I hit OK here, now you're going to see, rather than something taking about 2 or 3 minutes or 4 or 5 minutes to be able to cook up in real life, in about 20 to 30 seconds, ScanLab will be able to generate what your images are looking like, which is pretty exciting. And also, this is the cutest thing I've ever seen. No matter how many times I've seen it, I love it. It's one of my favorite things. Our designer really knocked this one out of the park. So, but after I see this, after we get done here, you're going to see, there we go. Let's take a look. I'll turn off my proposed lines. And now based off of this, I have a sagittal T1. So, I mean, and these are not, you know, we're not meant to be diagnostic, but we are meant to be able to show you, you know, and give you cause and effect for all of these. Now, soon there will be sandbox mode to where you'll be able to just play. Ever wondered why you never want to have a short TR and a really long TE? Give it a shot. You're not going to hurt anybody. And so it's going to look like garbage, but you'll be able to, you know, you'll be able to have this. And what we love about this is that you really can, I mean, if you really took advantage of this, you can have years of MRI experience in months, in weeks. I mean, if that's what you want. And just to show you a couple other things is, you know, we're seeing in this case, here's a couple little things. If you are a manager, if let's say this is some of our university partners really like this, they say, well, we haven't started working on upper extremities, so we don't want to have those available for the students. What we are doing at this point, we're going to start out with brain. So you can undo everything. And so you can say, well, if that's the case, we can unlock head right here. So I can, let's say everything else is locked. I'd always unlock this contrast lab because it's fun. And life's too short to not have fun. In 2020, we don't have much fun anyway. So, but anyway, you can say, okay, we're going to do the whole brain. Okay. But we're not going to do the pituitary yet. We're not going to do orbits yet. We're really going to focus this week on IACs and the actual brain. And we also are able to see who how long each individual student has spent inside the scan lab and things along those lines. And we're really getting some really, really terrific data here. So I don't love the way that we have it necessarily displayed, but that's something that's going to be changing in the coming weeks. But the data is there. And so we're seeing students that start out and they're going from, their scores are getting higher and higher and higher, every single one of them. So you start out with a 1. By the way, don't stop your ScanLab your ScanLab examination right in the middle because you're given a 0. But you can see if we go up here, we can be able to see on July 26th, that was this examination. And if you want to, you can actually click in there and it takes you to the feedback where you can see what the student did. Also, once again, not finished product completely, but you can be able to actually go through and see how well the student has done inside of these individual difficulty levels of all these different types of questions. Something else we're also really excited about is the Fluoro Lab. So one thing that is particularly intimidating to people that are just learning MR is, actually doing contrast enhanced MRAs, because with NSF, with gadolinium retention, anything like that, we don't want to necessarily mess around too much with contrast. And so what would be really cool is if we had something, a safe environment for you to be able to practice and get graded on your angio timing. So let's start contrast fluoro. And here we go. So now we can be able to wait for, depending on the time of center, since I have a short time of center, I need to wait for my entire carotid to be opacified, at least starting before I hit go. So at this point, this is a critical thinking question where you are judged based off of the time that you hit stop and go. And so in this case, we already have multiple body parts, pretty much everything in terms of all the types of MRAs that you do. And as time goes on, we're going to be adding more, like I said, cardiac goes into play very, very soon. We support multi-slice, multi-angle for spine imaging. And one last thing I wanted to show is you also have for critical thinking questions, something new that we've come along. Let's say someone says, well, Matthew, we haven't really tackled artifacts yet. Okay, we can turn off artifacts. So that way, anybody within the scan lab is not being judged based on something they've never learned before. Or let's say, okay, well, let's do safety though. We have not necessarily covered safety, but we want you to be able to, we want the student to know it exists and things like that. So, but I will only allow them to reach level 3 questions, and so they will be able to maybe miss some questions, but also know how big the world is and know what they don't know, and be able to change that. So you can be able to completely take away, I don't want patient screening, definitely want patient screening, but from this case you can say, well, we haven't covered pathology, or if we do cover pathology, just give me the easy stuff for the students. And we're getting in some really exciting ground here, and our clinical partners have been really pleased so far with what it is they've been able to do with their students or with their staff. But I mean, I don't know. I mean, Kathy, I know I couldn't have done it without you on this case, but I mean, do you see any kind of, I mean, being a guru of MR education, what would you say to this kind of tool? Oh, you're muted.
Sorry, I muted myself. I think it's undoubtedly a brilliant, additional tool for educators. And I think, one of the key things, if there are any educators are listening and watching this, is that I think this is a really important tool to allow you to enable your learners to make that very important link between theory and practice. That's really the holy grail, isn't it? If you're a healthcare educator, is, you know, in radiography, there's a lot of theory that is necessary to underpin practice. If we send practitioners out there without an understanding of the theory, then they're, you know, perhaps not going to be safe or as competent as they could be. And if we just teach them theory in isolation, it's completely meaningless, really, isn't it? And this has always been really difficult in MRI. I mean, in radiography, you can buy a relatively inexpensive sort of X-ray room and get your students to take x-rays of phantoms and that kind of thing. But, you know, an MR scan is expensive and it needs patients going through it, doesn't it, to sort of pay for it. And so it's always been really difficult to actually get MR learners to make that connection between the theory and practice quickly. You have to do theory in blocks of time, and then there may be, you know, weeks before in practice they're actually applying that. And this is going to be instantaneous. And I think, you know, having these critical thinking questions so that there's instant connection between what they've just done and the theory behind it, and where they've, you know, an instant feedback is going to make a massive difference actually to how learners gel that theory and that practice together. Because if you do that, then you understand it better. You know, it's just so hard, isn't it, when you can't make those connections, to actually understand the relevance of something like K-space, you know, which seems like a surreal concept, but actually it's vitally important to understanding why you're selecting parameters. And, you know, protocol optimization is something, you know, and being able to do that is something I've been banging on about boringly for 30 odd years. You know, it's the nuts and bolts, isn't it, of what a technologist or a radiographer needs to know. And there's so much sort of button pushing, as I call it, that just goes on, which is just, you know, clicking on things without understanding often why you're doing that and what is going to change in the image when you change those parameters. And that's because I think it's been so hard to put the theory and the practice together. And ScanLabMR just enables the learner. And it's not just students, it's practicing technologies, you know, to actually, oh, okay, that's why, you know, if I change the TR, this changes, or whatever the parameter is, you know. So I think that is a really key thing. The other thing that I would say, and I think this is something, Matthew, that sort of gradually evolved, really. We sort of gradually started to think, oh yeah, maybe that's a benefit too, is that there's some baby steps here towards some sort of standardization. You know, there was you and me and Anne as a, you know, our little team agreeing on slice prescription and other parameters. And, you know, the Handbook of MRI Technique is a reference for that. That in the last few editions has been written by consensus, by contributing authors from all over the world. And, you know, we're hoping, well, we're working on the 5th edition now, and again, using that as a reference in ScanLab. So we've got, I think, 2 really important resources that are going to say exactly the same thing. And, you know, the more consensus we get, the more standardization I think that there's going to be. And that's got to be better for patients, doesn't it? You know, if it means that patients don't have to be recalled because there is a general agreement on some things anyway, then I think that's got to be a great tool. And finally, I just said there's going to be obviously a ton of data coming out of this. And it's that this is something else that we discuss, that, you know, there's a need for some empirical research really on standards. And this is an ideal source of a ton of data that can be used to actually develop this necessary research in the future. So, you know, for all kinds of people, practitioners, managers, educators, researchers, I think ScanLabMR is going to be, you know, a fantastic tool, actually. So,
well, exciting times.
yes,
Exciting
absolutely.
times.
Yes.
Well, Kathy and Toby, thank you for spending your time with us. I know how incredibly busy you are, Toby. I can see the sun actually coming up in Kansas City now, so that's good. So I think one last thing I just want to show. If you go to ScanLabMR.com, you will be able to come back. If we just go actually to, there we go, to ScanLabMR. There we go. If you do, I'm sorry, I just did exactly what I did not want to do. If you go to the About Us or Contact Us, you can be able to request a demo or request a quote, or if you have any kind of support or anything along those lines, feel free to reach out to us. We don't mind getting together with you and talking about what we can do for your students or your technologist or radiographers that work with you. But we're really, really excited to be able to do this. So now what I'd like to do, if it's okay, is poll the audience and see if there's any questions that we can answer before we end this first session. Let's see. Let me look over here in the chat. Anything that anybody wants to discuss before we call it a day? If not, feel free just to reach out to us with your questions privately or anything like that. Okay, I think we just did the perfect demo. There's no questions. I hope that's a good sign. So, okay, I will go ahead. I will stop us. Everyone on Facebook, thank you for joining us. We appreciate it. Good to see everyone. Kathy, once again, thanks to Kathy, thanks to Toby, thanks to Ann Bright, Dr. Brian Dale, Chris Seitz, obviously, and everybody, the little village that made this all a possibility and more legitimate. It was a really something fun that we were able to do together. So come visit us, come see us, like us on Facebook at ScanLabMR. We're just getting started. So have a good day. Okay. All right, everyone, everybody that came to the actual launch today with us here inside of Zoom, thank you so much for joining us, and have a wonderful day. It was great to see you. Guys, thanks again.
Okay, all right, bye.
Our pleasure.
Bye.